All right, welcome. Today we are diving headfirst into one of the trickiest, most feared stations in any pediatric clinical exam. Yep, the short stature case. But don't worry, we're going to build a rock-solid method so you can absolutely master it.
You know that feeling, right? You walk into the room for a general case, your mind just goes blank. It feels so unstructured, so confusing, and it's just so easy to get lost if you don't have a clear plan. Well, that feeling of uncertainty, that's exactly what we're going to tackle today.
So the whole point of this explainer is to give you a simple, repeatable framework. Seriously, by the time we're done, you're going to have this mental checklist that guides you from the second you walk in the door all the way to your final presentation. We're talking about turning that anxiety into pure, unshakable confidence.
Okay, let's get started. The first 30 seconds, they are absolutely crucial. Before you even think about touching the patient, you need an action plan. And that plan? It's the 4Ds rule. Just think of this as your immediate mental sweep of the room. First up, dimensions. Does the kid look small for their age? Simple. Next, dysmorphism. Any unusual or distinct facial features. Then, distress. Is the child calm, anxious, maybe unwell? And finally, devices. Just scan the room for things like wheelchairs, orthotics, any kind of aid. See? This super simple checklist gets your brain organized right away.
All right, so your initial observation is done. Now it's time to get hands-on. First task, measurements. Because this is what's going to help us answer the most fundamental question in any short stature case. Is it proportional or is it disproportional?
And you know what? The distinction is way simpler than it sounds. Here's the deal. With proportional short stature, the body is small, sure, but everything's in proportion. With disproportional, either the trunk or the limbs are obviously shorter. And the rule of thumb to figure this out? It's fantastic. You just double the sitting height. If that number is within about 7 centimeters of the standing height, you're thinking proportional. If the difference is bigger than that, boom, you're likely looking at a disproportional cause.
And that's why that first distinction is so important. It immediately starts narrowing down your list of possibilities. Proportional causes? They point you towards syndromes like Turner's or Noonan. Disproportional, now you're thinking about things like achondroplasia or rickets. This is literally your first major clue in solving the case.
Okay, so we've observed, we've measured, now what? Well, now we dive into the core physical exam, and we're going to use our second powerhouse mnemonic for this, GPN. Think of this as your guide for the entire hands-on part of the assessment.
Yeah, just think of GPN as your physical exam roadmap. It's going to make sure you don't miss any of the key findings. We start from the ground up. G is for gait. Then we move to the P for, well, it's really the back and spine, and then we get to the N, which is the next set of key maneuvers.
So first up, G for gait. After you get permission, of course, you'll expose the legs up to the mid-thigh. And you really need to get down on one knee and inspect everything. I'm talking knees, skin, any bony deformations. Then you ask the child to walk. You're just watching, looking for any little abnormality in their gait that can give you some immediate clues. Okay, after the gait, we move on to the back. A thorough inspection of the spine, looking for things like scoliosis, is obviously vital. But the back exam also holds this one key test, a test that's going to determine the very next step in your examination. And here is a fantastic clinical shortcut. Just ask the patient to bend forward and touch the floor with their palms flat while keeping their knees totally straight. If they can do it, boom! You've just scored them 3 out of a possible 9 on the Beighton hypermobility scale, all in one single move. And this right here creates a critical fork in the road for your exam. It's a simple yes or no. If the test is positive for hypermobility, yes, your next job is to complete the rest of the Beighton score, right then and there. But if it's negative, no, don't waste a second. You proceed directly to our specific hand maneuvers for short stature.
Which brings us to the N in our GPN framework, the next key maneuvers. And these are all focused on the hands. And these 5 steps are just packed with diagnostic clues. First, the star. Have them spread their hands. This can reveal a trident hand, a classic sign of achondroplasia. Then, make a fist. You're looking for short metacarpals, like you might see in Turner syndrome. Next, you'll check the cubitus angle at the elbow and then use the thumb to shoulder test. These give you vital info about limb proportions. Is the shortening in the upper part of the limbs or the lower? And probably the most important thing, throughout all of this, always check for symmetry.
So, we've got all these individual findings, but how do we tie them all together? I mean, it's not just about spotting isolated signs, right? Let's take a look at how this all builds into a complete picture. We'll use Williams syndrome as a quick case study. This is where the magic happens. Your findings from that GPN exam now guide your next steps. So let's say a few things are making you suspect Williams syndrome. Your exam instantly becomes targeted. You're going to listen specifically for that murmur of supravalvular aortic stenosis. You'll check their hands for bounding pulses, you'll assess the neck, look really closely at the facial features, and then you'll grab your torch to check the mouth for a high-arch palate. You see how the system takes you from this general screen to a super-focused, hypothesis-driven examination? It's brilliant.
And there you have it. That is our systematic approach. Let's do a super quick recap of how this structured method is going to be your key to absolutely crushing this station.
Look, it all boils down to these two incredibly powerful mnemonics. You've got the 4 Ds for that first hands-off look, and you've got GPN to guide your hands-on physical exam. That's it. These are the pillars that are going to hold up your entire performance, and, I promise, they'll keep you from ever feeling lost in that room again.
You know, at the end of the day, success in these high-pressure situations isn't about memorizing a million different facts. It's about having a reliable system. Because when you have a method, you have control. And when you have control, well, that's when confusion transforms into confidence. So the real question to leave you with is, what other complex cases could a system like this help you master?